So I call this the speech. In specialty care, we end up seeing the same conditions and doing the same explanations over and over. So I go through it pretty quickly in the office. So I want to do it a little bit more thoroughly, and all of this is written down. So I'm an anesthesiologist, and we do many procedures in operating rooms. And I did additional training to do an interventional spine clinic where we can do office-based procedures under X-ray guidance for injections to treat people that have pain. Now, excluding headaches and abdominal pain, which we don't treat, the vast majority of all other sources of pain is either muscles, joints, or nerves. Muscles is not a serious condition. It can be painful, but it's usually localized. There's often a palpable cord, and there's lots of individual treatments. People take anti-inflammatories, muscle relaxants, heat or ice. There's stretching, massage, physical therapy, chiropractic, which are all individually effective. And if you combine multiple modalities, then it's synergistic and even more effective. But muscles is rarely a source of long-term pain or disability, so we really don't see a lot of that in interventional spine clinics. So the majority of our patients have pain that's either from joints or from nerves. And with both of those conditions, there's two things that contribute. There's some underlying structural degeneration of the joint or the spinal cord, which happens slowly over years and decades, really. And then at the time that the pain starts, there's something that has happened that has developed an episode of inflammation. And the narrowing, the degeneration that was already present with little or no symptoms, along with the inflammation, which is new, then together causes the symptoms. So the first thing we do is do treatments that is known to be needed to resolve the inflammation, and that's injections under X-ray guidance. The medicines that we're using are steroids, commonly known ones as like prednisone or cortisone. But if you take pills or get shots in the muscles, the medicine gets absorbed in the whole body. So the amount of it that's down where the problem is, even if it helps, it usually doesn't last. The trick is getting the medicines placed at the location of the problem. We're treating the source of the problem, not the symptom. So there's four ways that we can determine what's causing the pain. We go by the location of the pain. Sometimes we have testing like MRIs or imaging tests. There's a physical exam where we can stress certain structures of the body to see if we can reproduce the pain. And then there's the modifying factors of what people are doing that makes the pain better or worse. And those allow us to determine what the source of the pain is. And then once we have a diagnosis, then there's specific treatments. When the source of the pain is joints, then we do injections under X-ray guidance to put steroids in the joints. These joints are synovial joints, which means they're contained within a fibrous capsule. So once the medicine is placed there, it stays there. And usually with joints as a source of the pain, a single treatment is sufficient. Now, our medicine is a little bit more potent than prednisone and cortisone, but it's made preservative-free, so it's safe to use around the spine and skeleton. The other major thing that we commonly see is neurologic sources of pain, and that's from spinal stenosis, which is, again, a degenerative condition that happens very slowly. And then if people develop episodes of inflammation, that is when the pain can either get worse or new. Now, there's two types of tests that we use for neurologic sources of pain. MRI show the structure of the spine, and we see this condition of spinal stenosis, which is narrowing of either the spinal cord or the canals where the nerves exit. Or there's also electrodiagnostic testing where we can check the function of the nerves. And that allows us to identify which nerve is causing the pain. And there's two types of shots that can be done. We can place medicine, if we know which nerve it is, we can place medicines on individual nerves where the nerves exit. That's a nerve root injection. Or we can place medicines more centrally where the nerves originate, and that's epidural steroids. Epidurals are the same thing we do for women in labor, but rather than numbing for delivery, we're using steroids for inflammation. But the procedure is the same, and it's even easier because we can use the X-ray guidance. So people typically need one shot if it's a joint as a source of the pain, two shots if it's the nerves as the source of the pain. When we're treating spinal stenosis, people are dramatically better after the initial treatment as the inflammation is reduced. Most patients come back, the pain's no longer constant, becomes intermittent, and at least half gone. With that result, we would repeat the same procedure. If we get a result less than that, we do the other type of procedure, either epidurals or nerve root injections. We rarely get complete relief of spinal stenosis with a single treatment because these patients have the pain for so long that the episodes of inflammation are well established and they're dramatically better with one shot, but typically take two. And then with all of these conditions, once people are healed or improved, the improvement that they get is the portion of the pain that's from inflammation. And if there's any residual symptoms, then it's from the structure. So there isn't any test that can detect inflammation. So we begin the treatments by doing what we know is needed to resolve the inflammation, and that's injections under X-ray guidance. Once people are healed, then they would never have pain again unless they get a new episode of inflammation, and that's preventable. People can be pain-free and live full and productive lives for years or for life, even though they've had this underlying structural condition, and we have people with complete relief.